Okay, let's go through day 8 and the plan for day 8 with the 70-day plan leading up to the GPhC exam. So I'm going to tell you what I want you to cover for today, but at the same time I want to go through what you've covered already in the previous 7 days. So lesson plan for today is we want to go through the central nervous system. In particular, I want you to focus on Parkinson's disease. If you're a member on the MicroPharm platform, you will have access to all of these videos. If you're not a member, I want you to go through all of these topic areas in the BNF. So first thing is going through an introduction to Parkinson's disease, what it is, the symptoms associated with Parkinson's disease, the treatment of Parkinson's disease, levodopa and carbidopa, levodopa and benserazide, dopamine agonists, apomorphine, MAOB inhibitors, COMT inhibitors, and managing symptoms of Parkinson's disease, and then to summarize all of that knowledge. When it comes to the CNS, I want you to go through anxiety and insomnia. We have these videos on the platform. So an introduction to anxiety and insomnia, a treatment for anxiety, short and long-term insomnia, and the treatment for insomnia. I will include some of these videos on the platform on this YouTube video for free. So you can check those out and they'll give you a model of to what extent I want you to go through these different topics. For calculations, I want you to go through Module 4. Module 4 includes 12 different types of calculation questions from all the 12 types that could be asked in the GPhC exam. What have we done so far? On day 1, I asked you to go through an introduction to the GPhC exam, familiarize yourself with the framework, and go through the basics. I then told you to get started on calculations related content. In particular, I told you to go through calculation question pack 1. Then day 2, we focused on infections and endocrine system calculations. And I also asked you to go through, in the following days, to go through the cardiovascular system, the calculations workshop. We did blood and nutrition and more infections from day 5 onwards. We went further into the endocrine system, focusing on the endocrine system and thyroid gland with further calculations. And then we started the CNS system. In particular, we started with dementia and pain management. In relation to calculation, so summarizing what you've done in relation to calculation so far, you should have done 10 calculation questions on day 1. You should have gone through module 1, which includes 12 questions, and gone through question pack 2, which involves 10 questions, gone through the recording for the calculations workshop, and then gone through module 2, which includes a further 12 questions. From day 5 onwards, you should have gone through question pack. Just to let you know, here it's summarized day 2, 3, and 4. So it'd make more sense to have day 2 to 4 here. Then from day 5 onwards, asked you to go through question pack 3, which involved a further 10 questions. Go through module 3, which involved a further 12 calculation questions, and question pack 4, which involved a further 10 questions. These are some questions I'm going to lay out to you in relation to the infection chapter. And from what you've gone through so far, you should be able to answer these questions. So when it comes to principles of therapy, what factors do you need to consider before starting antibacterial therapy? Why is it important to consider a patient's renal and hepatic function before prescribing antibiotics? And how does the history of antibiotic use affect the choice of antibacterial therapy? When it comes to notifiable diseases, which diseases require immediate notification to the local health protection team? What steps should a registered medical practitioner take when suspecting a case of cholera, for example? How is COVID-19 classified among notifiable diseases? Then focusing on sepsis. What's the recommended initial treatment for patients at high risk of severe sepsis? Why is it important to take microbiology samples before administering a broad spectrum antibiotic in patients with sepsis? What are the key parameters in a patient with suspected sepsis? Then focusing on aminoglycosides. What is the mechanism of action of gentamicin? What are the common side effects associated with gentamicin use? Why is it necessary to monitor serum aminoglycoside concentrations in certain patients? And consider those therapeutic, essentially consider the goals that you're going for when taking peak and trough levels for certain indications, and why do they differ for certain indications. Cephalosporins, what is the difference between the various generations of cephalosporins, which cephalosporin is most effective against Pseudomonas aeruginosa, and what are the potential side effects of cephalosporin use. Glycopeptides such as vancomycin and teicoplanin. How do glycopeptides like vancomycin inhibit bacterial growth? What are the monitoring requirements for patients receiving vancomycin therapy? You can also add in here, what are the side effects associated with vancomycin use? Penicillins, what are the different indications for using using amoxicillin? How does coamoxiclav differ from amoxicillin alone? What are the contraindications of using flucloxacillin? And in particular, I'd like you to know what are the contraindications associated with coamoxiclav use as well. In terms of macrolides, what infections are macrolides commonly used to treat? What are the common side effects of macrolides such as erythromycin? Why should macrolides be avoided in patients with prolonged QT intervals? Metronidazole, what is the mechanism of action of metronidazole? For which types of infections is metronidazole typically prescribed, and what are the side effects associated with metronidazole use? For doxycycline, what types of infections can doxycycline treat? Why is doxycycline contraindicated in pregnancy? Why is doxycycline contraindicated for children under the age of 12? Quinolones, what is the mechanism of action of quinolones? What are the potential risks? Consider MHRA warnings here of using quinolones in elderly patients. Why should quinolones be avoided in patients with a history of tendon disorders? For tuberculosis, what is the standard treatment regimen for active tuberculosis? What are the common side effects of anti-tuberculosis drugs, particularly like isoniazid, rifampicin, but all of them? Pyrazinamide, ethambutol, consider all of them. How is latent tuberculosis different from active tuberculosis? When it comes to fungal infections, what's the first line treatment for aspergillosis? How is oral candidiasis typically treated? What precautions should be taken when prescribing itraconazole to patients at risk of heart failure? For helminth infections, what is the drug of choice for treating threadworm infections? How is tapeworm infection typically managed? What is the role of mebendazole in the treatment of roundworm infections? For malaria, what are the guidelines for starting malaria prophylaxis before travel? Why should mefloquine be avoided in patients with a history of psychiatric disorders? What precautions should be taken for malaria prophylaxis in patients with renal impairment? Viral infections, what are the treatment options for herpes simplex viral infections? How should chickenpox be managed in neonates? What are the key considerations in treating influenza with antiretroviral drugs? Consider COVID-19. What are the primary modes of transmission? Why is early notification of suspected cases important? And what patients are at higher risk of severe pneumonia? General infection control. Why is it important to use narrow spectrum antibiotics wherever possible? What are the risks associated with the overuse of broad spectrum antibiotics? How can healthcare professionals reduce the risk of antibiotic resistance? Drug safety and monitoring. What are the risks associated with nephrotoxicity in patients receiving gentamicin? How can ototoxicity be monitored in patients receiving vancomycin? What is the importance of TDM, therapeutic drug monitoring, in the use of glycopeptides and also aminoglycosides? What adjustments should be made in patients with hepatic impairment? How does pregnancy affect the choice of antimicrobial therapy? And what considerations should be taken when prescribing antimicrobials to elderly patients? And final additional considerations. How does bacterial resistance influence the choice of antibiotics in recurrent infections? Why is it important to take cultures before starting antibiotic therapy? We covered this previously as well. And what role does patient history play in the selection of appropriate antimicrobial therapy? So here are some points for you to take away. to go through what you've revised so far and see if you're able to answer these questions. If you're not, look up the answers for these questions. In particular, everything that I've covered today, these questions are based on the infection study guide produced by MicroPharm. So you can actually find all the answers to these questions in the study guides that we offer. So those of you who are members, you can just head over to the study guide to find the answers if you don't know them off the top of your head. In this video, I'm going to include a few videos from our CNS module for Parkinson's disease, our CNS module for anxiety and insomnia, and some calculation, example calculation questions from our modules. Hopefully you found today useful, and I will see you tomorrow for day 9. In day 9, I'm going to do the same thing with asking you questions about the endocrine system.
In this teaching, I'll be talking about Parkinson's disease. So this comes under Chapter 4 in the BNF, and the GPhC have highlighted in the framework that Chapter 4 of the BNF, which is the CNS chapter, is a high-weighted topic, which means it's more likely to feature in the exam, and the GPhC have defined high weighting as being 60 to 70% of the questions. So these are the topic areas that I'll be discussing: the background and diagnosis of Parkinson's, including any potential differential diagnoses, and I'll also talk about the pharmacological management of the non-motor and motor symptoms of Parkinson's disease. That will sort of form the bulk of this teaching, and the adverse effects and monitoring required. And I'll be using the NICE guidelines as a reference throughout this teaching. So what is Parkinson's disease? Parkinson's disease is a neurodegenerative disorder that affects dopamine-producing neurons in the substantia nigra, which is located in the midbrain. There is basically a degenerative loss of dopamine-secreting nerve cells, which results in a slow, progressive, and worsening of motor function, as well as other symptoms that I'll go into. As we get older, it's normal for cells in the substantia nigra to die, and it happens in most people at a very, very slow rate. But in some people, those who are diagnosed with Parkinson's disease, the loss unfortunately happens quite rapidly. Most people who are diagnosed with Parkinson's would have already lost about 50 to 70% of those neurons, because that's when the symptoms start to show. So just a sort of brief background into the epidemiology of Parkinson's disease. So it's more common in the elderly. There's a 1.7% incidence rate in people aged 80 to 84 years, as you would expect, based on what I've just said. By 2025, the estimated prevalence of Parkinson's disease is actually expected to increase by about 23% because of the aging population and the fact that the population is growing. Currently, Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's, and about 1 in 37 people are diagnosed at some point in their lifetime. So as an example, in 2019, there were about 8.5 million individuals with PD worldwide. It's more prevalent in men compared to women, but 1.5 times more likely to have Parkinson's disease than women. So in terms of risk factors, not really any screening tests or sort of known biomarkers that might indicate someone has Parkinson's disease. But there are sort of a constellation of factors that are linked to it. We don't know exactly what causes PD, what causes that sort of progressive loss of dopamine producing, but it's likely due to a blend of genetic factors and environmental factors and probably a lot of unknown factors. About 10 to 20% of Parkinson's cases are linked to a genetic cause, but we're not so sure about the sort of remaining 80 to 90%. People who have a parent or sibling who have Parkinson's are about 2 times more likely to develop Parkinson's themselves. Gene changes that have been identified that cause Parkinson's disease be identified in people, but those sort of specific gene changes are uncommon, except in really rare cases with many family members that are affected by PD, which is rare. Some environmental triggers like exposure to chemicals like pesticides, herbicides, or working with heavy metals, detergents and solvents that might, they've been implicated, they might potentially contribute to the cause of PD, but it's unlikely to be a sole cause. Risk is so small. The biggest risk factor for developing Parkinson's is aging. The average age of onset is about 60 years old, and as I mentioned earlier, it's a more common condition in the elderly. I've also mentioned that being male puts you at a higher risk of developing Parkinson's. Although it's not 100% certain, it is thought that head trauma, like blows to the head, a person's risk of developing Parkinson's disease, but then not everyone who has had a head trauma will develop Parkinson's. And then also some neuroleptic drugs, like antipsychotics, can cause pseudo-Parkinson symptoms like tremors and shakes. So that's it, sort of a brief background to Parkinson's. So to kind of get to the symptoms and how we treat those symptoms, I've broken down the symptoms into motor and non-motor. It's easier to learn that way. So starting with motor symptoms, and to remember them, you can think TRAP. So the hallmark symptom of Parkinson's is tremor, where people will have involuntary rhythmic shaking, trembling, and pin rolling, which is where they might rub their thumb and forefinger back and forth. Trembling is usually at rest, and there'll be reduced shaking when they're doing tasks like holding a mug. There's also rigidity, so that's the R, where people will have raised muscle tone, which results in muscle stiffness, and people can get pain with these stiff muscles, and that can limit their range of motion. Then there's akinesia, which is the loss of automatic movements, which can result in slow movement, also known as bradykinesia. Akinesia is the loss of control of movements, where people might have the decreased availability to perform unconscious movements. So when you're walking, people with Parkinson's might move in shorter steps, like drag or shuffle their feet as they try to walk. I also struggle with other tasks like getting out of a chair, because the signal of going, I want to get out of this chair, to the actual movement is delayed. So they might even freeze mid-action. And then finally, there's postural instability, where people with PD will experience issues with balance. Their posture might become stooped over time. It also means that they're at an increased risk of falls. There are some other symptoms that are associated with Parkinson's, like speech changes, where people speak softly or quickly, might slur their words or hesitate before talking. They might also have a sort of more monotone speech. Also be writing changes, where people with PD find it hard to write and their writing becomes small. That can often be a bit of a marker if someone needs to get tested for Parkinson's. The non-motor symptoms relate to the other symptoms that occur elsewhere in the body as a result of that lack of dopamine in the substantia nigra. There are neuropsychiatric symptoms that are related to the neurological dysfunction. If you've listened to my other talks on 4, then you'll know the importance of dopamine for our mood, motivation, sleep, and lots of other things. Parkinson's can experience anxiety, depression, as you would expect with a chronic degenerative condition, even psychosis, which can happen in about 20 to 40% of patients, and dementia. Excessive daytime sleepiness can happen. Usually it tends to be more related to the medication that's taken for Parkinson's, which we'll go into. There can also be sensory disturbances where people might experience pain or issues with their smell. And then there are autonomic disturbances, which is related to issues with the autonomic nervous system, which is responsible for our involuntary physiological processes like regulating our heart rate, blood pressure, breathing, and also sexual arousal. And these symptoms can occur as arise from disturbances of that symptom. So the diagnosis of Parkinson's can be quite difficult, and usually it's based on the TRAP symptoms that I went through. Clinical assessment would then be done, and the criteria of this comes from the UK Parkinson's Disease Society Brain Bank Clinical Diagnostic Criteria. It's a bit of a mouthful. You don't need to learn this off by heart, it's just to be aware. But basically, it has steps to follow, which include symptoms, exclusion criteria, and specific diagnostic characteristics for Parkinson's. Patients can actually donate tissue to this brain bank for confirmation of a diagnosis and also for research. So NICE guidelines actually recommends that the diagnosis is reviewed regularly and that patients diagnosed should be reviewed every 6 to 12 months. It's quite a serious diagnosis because it's essentially a long-term chronic disease that's only going to get worse. So it's really important that it is the correct diagnosis. There's a type of imaging test which is used to check the perfusion and functionality of specific tissues, which can help differentiate an essential tremor, for example, versus a Parkinson's tremor. Then there's also something called a DAT scan, which isn't mentioned in the NICE guidelines, but it can help by allowing visualization of the dopamine system in the brain, kind of like an MRI, but having a DAT scan isn't always necessary to diagnose Parkinson's. So as I said, it's really important that Parkinson's is diagnosed correctly, requires, medication for the rest of their lives, and it's only going to get worse. So it is really important that we're getting the diagnosis right. So put some other differential diagnosis on the slide there just for your information, and you can have a think of the other possibilities when it comes to the kind of symptoms that these patients present with. So moving on to the pathophysiology of Parkinson's, the main thing to take away from this is that there is a reduction in the amount of dopamine in the basal ganglia. So the basal ganglia is important for motor control, and also other skills like motor learning, executive functions like thinking, cognitive processes, and also learning and memory. And dopamine is produced in this really important area in the brain, and it's very important to our ability to function. So as I mentioned, there's an area in the basal ganglia, the substantia nigra, which I've mentioned a few times. Dopamine-producing neurons are based, and in Parkinson's, there is a progressive degeneration of dopamine-producing neurons, which results in the formation of Lewy body deposits, and then that prevents the neurons from actually producing dopamine. And as I mentioned before, by the time people are diagnosed with Parkinson's and are presenting with symptoms of Parkinson's, about 50 to 70%, sometimes about 80% of dopamine stores are already lost. This diagram quite nicely summarizes the main pathophysiology of Parkinson's that you need to understand. In a normal functioning neuron, lots of dopamine is released and received and can produce normal movement and good motor skills. But in a person with Parkinson's, the neurons are damaged by Lewy bodies, which means less dopamine is produced, released, and received, resulting in movement disorders. This teaching is on anxiety and insomnia. I've grouped these together because there's an overlap of some of the drugs used. Anxiety and insomnia come under Chapter 4 in the BNF. The GPhC have highlighted in the framework that Chapter 4 of the BNF, which is the CNS chapter, is a high-weighted topic, which means it's more likely to feature in the exam. And the GPhC have defined high weighting as being 60 to 70% of the questions. So these are the topics that I'll be going over. With regards to treatment, I'll focus more on benzodiazepines in terms of the mechanism of action, adverse effects, monitoring, etc. Antidepressants are also used for anxiety, but you can refer to the teaching on depression for that because the doses are the same, the side effects are the same. So I'm sure we're all familiar with the feeling of anxiety, which is defined as an unpleasant feeling or a feeling of unease. It can be triggered by many different things: stress, facing a difficult situation, or feeling some sort of threat. And it's a completely normal emotion that everyone will experience more than once in their lives. Anxiety disorders, however, are more severe. An anxiety disorder is when the anxiety doesn't go away. It interferes with functioning, and it can get worse over time. The feeling of worry or fear is persistent, it's excessive, and it's intense. And it can occur in normal everyday situations that wouldn't normally trigger anxiety. Many people who have anxiety also have a diagnosis of depression, but also people with long-term physical health conditions can have anxiety as well. One of the most common is generalized anxiety disorder, which affects about 1 in 25 people in the UK. General anxiety disorder is a long-term condition characterized by persistent and excessive anxiety about activities or events. So the anxiety experience is out of proportion to the actual situation occurring. So for example, someone with social anxiety is invited to a social gathering, but they might be very avoidant of that and not go out because they're just so anxious about experiencing embarrassment or judgment. And generalized anxiety disorder often occurs with depression, as I mentioned, or it can occur with other anxiety disorders as well. NICE guidelines focuses on managing general anxiety disorder, so I'll mainly be referring to this when I'm talking about treatment. but generally treatment is quite similar across the different anxiety disorders. So there are other anxiety disorders, as I mentioned. OCD is another common anxiety disorder, and it's characterized by obsessions, which are intrusive thoughts, images, urges, worries, or doubts that repeatedly appear in the mind. And the compulsions are behaviors or mental acts that are done repetitively to relieve the unpleasant feelings caused by the obsessive thoughts. Panic disorder involves episodes of sudden feelings of intense anxiety and fear that reach a peak, which are called panic attacks. There are somatic physical symptoms associated with this, such as chest pain, shortness of breath, palpitations. Also note that panic attacks can occur in other anxiety disorders as well. Social anxiety disorder is a feeling of intense anxiety, worry, or fear of social situations, and that can lead to avoidance. So usually people will feel that they're going to be embarrassed or they're concerned about receiving judgment from others. Agoraphobia is the fear of places or situations where escaping or receiving help would be difficult. And again, there's avoidant behavior with this type of anxiety as they fear being trapped, helpless, or embarrassed. There are many more types of anxiety disorders, but these are the common ones. So these are the general symptoms of anxiety that can be related to most of the disorders. Of course, each disorder will have some specific symptoms, like in panic disorder, there are some specific physical symptoms I mentioned. But again, these can occur in any of the anxiety disorders, so it just depends. But something like OCD with the repetitive, obsessive mental acts or behaviors is quite a specific symptom of OCD. And also note that some of these symptoms here actually overlap with depression. So things like poor sleep, difficulty concentrating, irritability. And treatment focuses on trying to manage the symptoms that interfere with daily functioning. So, as I mentioned, anxiety is a normal emotion and it's the brain's way of alerting us that something is wrong. But in anxiety disorders, the brain overestimates a perceived threat, which results in an inappropriate response. So, like in social anxiety, the fear of being embarrassed is perceived as a real threat to that person's life, and the brain produces a response to react to that to protect itself. The neurotransmitters thought to be involved are listed there. Noradrenaline is important for our fight or flight response, and it's what kicks us into action. Serotonin is important for improving our mood and also important for reducing anxiety. So lower serotonin activity can actually contribute to anxiety. Dopamine is important for anxiety modulation. So high levels of dopamine produces anxiety, and it can also cause insomnia and hallucinations. And finally, GABA is known for its calming effect. It's necessary to relax the mind and the body, and it's really important for a good night's sleep. And this is where benzodiazepines act, which I'll go into a little bit more later. So I thought I'd outline the process, the pathophysiology of anxiety, because it helps to sort of understand treatment. So this is a process that happens in everyone, but in an anxiety disorder, it's triggered often and it's overstimulated. The trigger that kickstarts the process could be anything, depending on the disorder. So, for example, in general anxiety disorder, people often describe always having a feeling that something is going to happen, something bad's going to happen, or they just feel overwhelmed by everyday things. For someone with agoraphobia, the trigger could be having to enter a crowded space. So the trigger causes activation in the amygdala in the brain, which is the core fear system in the body, and it's also important for emotional processing. In an anxiety disorder, the amygdala inappropriately perceives the trigger as dangerous. So this causes a stress signal to be sent to the hypothalamus, which is important for homeostasis and it controls many of the important body processes such as temperature and hunger. So the stress signal causes the hypothalamus to activate the sympathetic nervous system via the adrenal glands, and that releases adrenaline into the bloodstream. Adrenaline causes many physiological changes that invoke a physical response to kick the body into action, like I mentioned before. So things like a faster heartbeat, increased blood pressure, more oxygen to the brain, release of glucose and fat storage from the body. And these can happen before we even become aware of them happening, and it enables the body to respond quickly without being consciously aware. After the initial release of adrenaline, the hypothalamus activates the HPA axis. The HPA axis involves a network of the hypothalamus, pituitary gland, and adrenal glands. And this network is really important for the stress response via hormone signals, which keeps the sympathetic nervous system activated. So it keeps the body and the brain in a high anxiety state in anxiety disorders. As the brain continues to perceive the trigger as a dangerous threat, the hypothalamus releases corticotropin-releasing hormone, and that travels to the pituitary gland and triggers the release of adrenocorticotropic hormone. This hormone stimulates the release of cortisol from the adrenal glands. And we all know that cortisol is the stress hormone. It keeps the brain on high alert. So in an anxiety disorder, this process is sort of ongoing, and it's triggered often, and it's overstimulated. The process is terminated when the parasympathetic nervous system is activated, but in those with an anxiety disorder, the system doesn't really function as well as it should, and people with anxiety will often say they really struggle to relax. So NICE guidelines recommend a stepped care approach for people with generalized anxiety disorder. Aim is to use the most effective but least intrusive option. Psychological and self-help interventions are implemented first, and it's really important that patients understand that medication is only going to take them so far. It's really a very psychological disorder, so it's really important that patients have processes in place that they can apply to help themselves. If psychological and self-help interventions don't help manage symptoms, or there's marked functional impairment, then NICE recommends using high-intensity psychological interventions such as CBT or using a drug treatment. Often patients will have both. They'll have psychological intervention and they'll also be on drug treatment as well. So SSRIs are first line. Sertraline is usually the drug of choice as it's the most cost effective, but it's not actually licensed for GAD. It's licensed for OCD, panic disorder, PTSD, and social anxiety disorder though. But as with many drugs in mental health, even though it's not licensed for GAD, it's very commonly used. If sertraline isn't effective, then there are two options. So you can either try an alternative SSRI, which is what happens commonly in practice because there's a lot of variability in terms of the efficacy of each drug depending on the person. Or you can switch drug class and try an SNRI like venlafaxine. But also note that not all SSRIs and SNRIs are licensed for all types of anxiety, so just be aware. Pregabalin is a third line option if a person can't tolerate SSRIs or SNRIs. This is a Schedule 3 drug, so it's quite important to bear in mind the risk of drug abuse, and a person's history has to be evaluated before starting this drug. Pregabalin is also used in pain as well, and there is a link, as I mentioned before, between chronic pain, anxiety, and depression. Antipsychotics shouldn't be used in anxiety unless there's a comorbid diagnosis. For example, someone with resistant depression or psychosis. Sometimes antipsychotics can be used in combination with SSRIs for OCD because sometimes OCD can present with some psychotic features, so it can be useful in those areas. The general principles of prescribing SSRIs, including side effects, are covered in the depressing teaching, so I won't go into detail here, but it's just to remember to consider the increased bleeding risk, so look at the other medications prescribed and be cautious if they're on something like aspirin or regular ibuprofen. In these cases, you'd consider PPI cover. Also remember that young patients are at a higher risk of suicidal thinking and self-harm, so they should be counselled on this and reviewed within 1 week of starting an SSRI. When you start any medication, the effectiveness should be reviewed every 2 to 4 weeks during the first 3 months of treatment and then 3 monthly.
Right, so hello everyone. My name is Encasia. I am one of the clinical educators for calculations on the MicroPharm platform, and in today's session, we're going to be going over molecular weight. Now, I think it's safe to say that I'm in the very, very, very small minority of people that still enjoy medicinal chemistry and arguably still use it on a day-to-day basis. And I'm sure there were many of you who were told during your MPharm degree that the moment you graduate, you can forget all about medicinal chemistry. You don't need to know it anymore. It's not actually useful in everyday practice. Well, that's partially true. I mean, you can still use medicinal chemistry or certain core fundamentals of them if you'd like to. I use log P, for instance, if I think about permeation or absorption of certain drugs. That being said, though, you still need to know how to do these calculations for the registration assessment. So you're nearly there. You're nearly rid of this area of chemistry, but all the same, they aren't too difficult to handle. And that's what we're going to look at in today's session. But before I get into the nitty-gritty of it, again, I want to remind all of you that your success as far as the calculations component of the registration assessment goes all comes down to understanding the questions. Know your question types. Remember that each assessment is likely to include at least one calculation question involving each of the following in part 1. I also want to remind all of you that calculations aren't impossible and they are part of a pharmacist's day-to-day life in many different forms, no matter whether you're in primary, secondary, tertiary care, or even cross-sector. You are able to navigate these questions as an MPharm student. You are able to navigate them now. Remember your time management. Remember that on average, you have about 3 minutes per question, which is more than enough time for you to attempt the question, check through your working, and if you're really time savvy, even attempt the question again to see whether you get the same answer. Remember to think about the context as well. This is not just a calculations assessment, this is a pharmacy practice assessment that is being looked at or examined through the prism of calculations. So think about what is feasible, think about what can actually happen in reality, what's realistic. And finally, highlight part of the question. Break down the question into smaller bits to make it easier to understand, and highlight keywords so you can really focus on the important parts. With all that being said, let's jump right into it. When we think about molecular weight, I suppose that's the name suggests, it refers to the weight of molecules, and this isn't a new concept from GCSE, A-level chemistry, or even your MPharm, and it's generally the sum of your atomic masses. Now, let's take sodium chloride, for instance. Okay, sodium has an atomic mass of 23 grams per mole. Chlorine has an atomic mass of 35.5 grams per mole. If I put sodium chloride together, I'd have a relative formula mass of 58.5 grams per mole. You do not need to memorize that. I just memorize it because that's what I do with my free time. You'd be given that information in the question. Okay, you are not required to memorize the periodic table by any means. In terms of remembering moles and moles-like calculations, if you still have access to your A-level chemistry or GCSE chemistry notes, that might be useful just for the equations. But if not, don't worry, because I put all the equations there for you. You can calculate the number of moles by dividing the mass by the relative formula mass. Millimoles is really similar. You're just factoring in 1,000, that's your factor. Remember that 1 mole equals 1,000 millimoles, and 1 molar, when we think about solutions, is the same as saying 1 mole per decimeter cubed, which is also the same as saying 1 mole per liter. Okay, so again, these are all things for you to think about and remember as you're targeting these questions. Here's an example of such a question. We have Miss S, who's a 29-year-old lady, and she's being started on lithium carbonate prolonged release tablets for the treatment of mania. And just because it's good practice to remain on the same brand of lithium and specify it when prescribing, I've just popped in there that it's Priadel. She's been reviewed by Psych, and they've recommended a starting dose of 1.2 grams to be taken daily. Lithium carbonate, I should say, is available as a 400 milligram MR tablet. The molecular formula for lithium carbonate is lithium, or Li2CO3. The molecular weight for lithium is 7 grams per mole, carbon is 12 grams per mole, and oxygen is 16 grams per mole. What quantity of lithium expressed in milligrams will Miss S receive daily? Give your answer to the nearest whole number. I'm going to pause the video, give yourself 3 minutes. When time is up, and when you're ready to go through the answer, press play. Okay, I think we're ready to get into it. Now, with this question, if you took a little bit more time, that's not a problem because I'm sure you did lots and lots of scribbling and lots of working things out with your calculator. And what you probably found was that you spent a lot of time calculating the relative formula mass of lithium carbonate, and that's because you might not have done that in a while, which is absolutely fine. Okay. Again, I encourage you to do your working out and really state it clearly so you can follow what you did. Granted, the examiner is not going to see your working out, but if you can see your working out, you can see whether you've done the right thing or whether you may have gone wrong somewhere. And that's also important to remember. So the first thing that I would probably do here is I'd calculate the molecular weight for lithium carbonate. Now I calculated that to be 74 grams per mole because I've got Li2, so that's going to be 14, 7 times 2. Carbon is 12, and then I've got 3 lots of oxygen, so that's 48. So 48 from the oxygen plus the 12 from the carbon gives me 60, and then 60 plus the 14 from the lithium gives me 74. So the molecular weight for lithium carbonate is 74 grams per mole. Now I know that moles can be calculated by dividing the mass by the relative formula mass. The total mass, okay, here is going to be 1.2 grams, okay? So I'm going to divide 1.2 by 74 grams per mole, and note here that my units are the same, okay? Grams per mole, okay? So when I divide grams per mole by grams, or rather, when I divide grams by grams per mole, my unit will be in moles. The next thing that I then need to think about is the mole ratio. Okay, now here I've said the mole ratio of lithium carbonate to lithium is 1 to 2. Now that might seem a bit weird to you, but actually I want you to imagine it, and you may want to write this down as I explain it. If I wrote out lithium carbonate, so Li2CO3, and it dissociated, that formula, Li2CO3, says that in lithium carbonate that consists of 2 lithium ions and 1 carbonate ion. So from that perspective, if lithium carbonate breaks down, for every 1 lot of lithium carbonate, I get 2 lots of lithium ions. So whatever the number of moles of lithium carbonate I have, I'll have double the number of moles of lithium. So I'm going to times that by 2. So 0.016216222, which is a mouthful to say, times 2, then gives me 0.0324324 moles. Okay, and that's the number of moles I have of lithium. I can then multiply this by the atomic mass of lithium, which we know to be 7. Okay, that then gives me 0.2270273 grams. To convert that into milligrams, I'm just going to times that by 1,000. So in milligrams, I end up with 227 milligrams, and that's how much lithium Miss S is actually receiving daily. So yes, she's receiving 1.2 grams of lithium carbonate, but that doesn't mean that she's receiving 1.2 grams of lithium. That's how much of the salt she's receiving, and that's important to keep in mind. I hope that made sense as far as your molecular weight questions. I appreciate the molecular weight might be a little bit challenging. It might be one of those areas that you really sort of break down the question, but that's one of the things that we encourage. Break down the question into very clear bullet points that you can follow, and that will help you succeed with these types of questions. Do remember that here at MicroPharm, we are here to support you if needs be, but otherwise I wish you all the best as you prepare for the calculations component of the registration assessment.